Welcome, everybody. As I said to some of you while we were waiting, this is going to be one of those meetings where people are popping in and popping out. And so we're just all going to go with the flow as people come in and out. And that's just fine. Let us all hope our next meeting is in person, which will be a very nice thing to have happen. I am going to open the meeting with a request for a motion to approve the minutes. Remember, I will have to do a roll call. We do have a quorum, so it will be fine. May I have a motion, please?
So moved.
Second.
Second.
Thank you. Any discussion on the minutes? They were sent out in advance, so no discussion? Great. Now I'm going to do the roll call, and I think I know the people that are here. So Lauren Peters.
Yes, approved.
Laura Adams.
Yes, approved.
Niels Protov.
Yes.
Rob Birmingham.
Yes.
Great. And Sandra, are you there too? I think I saw you. Sandra, yes. Yes, I do this to you every time. Thank you. Ray.
Yes.
Okay, terrific. So we're going to have three agendas for today's meeting. The first will be our usual executive director's report, and that's where we can get an update on the APCG, the budget, thoughts about new reports, opportunity for conversation. Then something that's really going to be interesting. Hello, David. We just approved the minutes. We had a quorum. Then we're going to have a presentation on the health equity report, which is really very exciting because this is something that is interesting and important work and new, not often been done. So I think it's going to be terrific. And then we're going to have a report on the findings of the annual report. You all got a copy. It was very long, it was very detailed. And as we talk about that in particular, I think it would be really helpful for the council members to think about how do we calibrate this kind of report in this crazy world, particularly the last two. Is it even rational to compare data from 2020 to 2019? Of course, we understand it's an annual report. It has to be an annual report. That's part of our enabling legislation. But how do we think about it and how do we make it actually more useful going forward? How do we think about the CARES Act and one-time payments that don't skew things up as we compare costs? How do we think about, over maybe looking at a broader perspective? But some of you in particular have really good insights, and I you know who you are, into how to use this kind of information data. Because if you look at just one data point, it's very bizarre because it's been a bizarre couple of years, especially in healthcare. So looking forward to some conversation, some discussion. And now I'm going to turn it over to you, Ray, to begin with the executive report.
Thank you very much, Chair Donahue. Excellent opening comments. I appreciate that very much. Let me start first with, and I'm going to be brief because we have the two presentations that we have today are very substantive and I think provide an opportunity for a lot of questions and discussion. It's CHIA's annual report. It's, each year we do it, it's been getting bigger and better, but because this covers 2020, the first year of COVID, it's, even bigger and, more detailed than previous years. We want to have a significant discussion around that. And then similarly, the health equity report we'll brief you on is very groundbreaking for us. And I think in each one of these, we're always interested in hearing from the members of the council on kind of the implications of what we're showing you. So like, what would you think that we should be doing next with this? And in particular, as we go through the annual report, that's one of the things that we'll be interested in hearing is questions that people have, certainly, but just suggestions for further analyses that are suggested by the data we're presenting. So let me start first with a finance update. I'll be brief in this one as well. We've done more detailed finance updates lately, but it's not appropriate for every Oversight Council meeting to have a detailed finance presentation. We'll do another one in June when the fiscal 23 budget process is further along. By then, or between now and then, the CHIA will have its annual statutory budget hearing, which is scheduled for April 20th. So we will have that, and then also kind of the House and Senate. The House should have finished their action on the budget, and the Senate will either be finished or pretty far along. And so we'll have further, we'll do a more detailed presentation in June on CHIA's budget. Since we last met in December, the governor has filed his budget recommendation for fiscal 23. CHIA was very pleased. It was very close to the number that CHIA had requested, somewhat less. CHIA has decided that we can manage to the governor's number. And so we've let the Ways and Means committees know that the governor's number is good with us. So we're pleased at the way the FY23 budget cycle is progressing, but it's early in the process. So in June, we'll have a much more detailed update on CHIA's finances. Turning to the executive director's report, as I said, I'll be brief because we have such good discussions coming up around the presentations that we have. I'd like the council to know we are in the process of returning to the office. And so I want to echo Faye's comments about hopefully our next meeting will be in person as well. We've started voluntary return. We're going to be bringing back CHIA's teams in a more formal and mandatory way starting in May and June. And then expanding from there. In the fall, we're going to be adding a day to the schedule. So we've started the process, but we're going to be thoughtful and flexible as we go about it because as we've learned over the past 2 years, things have a tendency to change. And so we're making plans, asking staff to be flexible, but looking forward to getting back to work in person. So other than that, I want to make note that the governor has filed a health reform bill, which she is very excited to see that. The legislature has been active in this regard as well. There's been activity in both branches on health reform issues. And so now that the governor has put something into the mix, we'll see where things come out. But CHIA is always, and you'll hear a bit more about this from Emma a little bit further on after I speak. But we're tracking this very closely. Mostly because the type of work we do often requires lead times. And so we like to understand where things are heading so that if there's something we need to be doing in advance or in preparation, we can be doing that. So anyway, we've looked at the bills that have been filed and we feel confident about our ability to respond to any of the challenges that we're handed. So we'll see where things go, but it's something we're looking at very carefully. On the APCD, we will not do a detailed update on that this meeting either, but again, in the future for sure. But we continue to work on the production system, adding the final bits of functionality and getting ready to use it in more of a kind of an operating and production fashion. And a key question or a key thing for the Oversight Council members to think about, in particular as we're doing the annual report, is, as I said, the types of follow-up analyses that you think would be interesting or insightful for CHIA to work on. And so an example would be, we see at a high level, the data in the annual report is largely taken from aggregate data that we collect from health plans. And so as a result, there's limits to how far we can drill down using the annual report data. With the APCD, we can go much, much deeper on really any of the topics that we choose. And so it's kind of using, switching from one tool to the other. And you can't do that with everything because there's a certain amount of effort and resources required. But in any important area, really that the annual report highlights an issue, we generally have the ability to go deeper. So as you hear the presentation, please think about the issues that you think we should be exploring in more depth. I believe that's really it. I know that, CHIA is working on a number of new things that I would like to give more detailed updates on, but they're some of them are in the process of procurement activities, and so there's limits to what I can say. I will say that we're continuing to, we're very interested in primary care and behavioral health measurement. We've now done 2 cycles of data collection on that, and that's something that's featured very prominently in the governor's bill. So we continue to work on things related to that. We're interested in standing up a primary care dashboard, and we've had some discussions about what would be involved in having a dashboard that policymakers and thought leaders could turn to that would have key metrics about the health and the functioning of the state's primary care delivery system. So we're thinking about that, but there's procurement requirements that we have to do before we can choose a partner. So that's not something that is quite done. Workforce is an issue that again and again comes up in policy discussions in healthcare these days. And so as I mentioned, this is something that CHIA is quite interested in. The HPC has been called on to do a report on workforce issues, and we will be eager consumers of that because we ultimately, CHIA doesn't have any regulatory say around workforce issues by and large. It's other agencies that regulate any particular part of the healthcare workforce, but we do think that this is an issue that would benefit from systematic measurement, and that's something that we can bring to the table and design it in such a way that the other agencies that would use the data, can guide us in how we ought to be doing these measurements. So you'll hear more about our activities in the area of workforce at future meetings. All right, I think that actually is all that I've got for the executive director's report. I'm going to turn it over now Emma, to you for an update on legislative and publication issues.
Great. I'm going to ask you to pause for 1 second and to make sure the council members don't have any questions for the executive director in terms of what's going on in the agency, things that might be in the governor's bill. Any questions from anyone? Good. I'm going to ask, go ahead. I'm going to ask about the governor's bill. Is there anything particular in the governor's bill that impacts CHIA?
I am happy to cover that in the next
great.
slide, actually.
Perfect, then don't do that.
Great timing.
Great, wonderful segue in. Okay, Emma.
Exactly.
I see no hands raised. It's all yours.
All right, thank you, Faye. As Ray mentioned, I'm now going to review a few legislative updates since our last council meeting. In February, the Senate passed an act relative to pharmaceutical access, cost, and transparency, otherwise known as the PACT Act, with the aim of controlling pharmaceutical costs in Massachusetts. Regarding CHIA, if passed, the bill would authorize CHIA to collect additional data from pharmaceutical manufacturing companies and pharmacy benefit managers, commonly referred to as PBMs. It would also require CHIA to incorporate this data and analysis in its annual report. In terms of the bill's status, it has been referred to the House Committee on Ways and Means and is awaiting further action in the House. Next, I want to touch on a bill that was recently filed by the governor, an act investing in our future of our health. As Ray mentioned, this bill largely mirrors the healthcare reform bill filed by Governor Baker in 2019 prior to the pandemic. At a high level, the bill focuses on prioritizing primary care and behavioral health, managing healthcare cost drivers, and improving access to high-quality coordinated care. This legislation has several sections that pertain to CHIA. If passed and signed into law, the bill would set system-wide primary care and behavioral health spending targets for providers and payers, which would be measured by CHIA. It also directs CHIA to report on additional measures of prescription drug utilization and spending, as well as conduct a study on the healthcare workforce. The bill has been referred to the Joint Committee on Healthcare Financing, and the next expected step is to set a date for the bill's hearing before it can advance in the legislative process. Lastly, I just want to remind the Council of a few upcoming legislative dates. The deadline for the Healthcare Financing Committee to act on bills in their committee is next week, and that will give us a clearer picture of what legislation is still in play this session. Regarding healthcare legislation, so far this session, the Senate has passed a mental health bill and the PACT Act, while the House has passed a bill enhancing the market review process. Since this is the second year of the General Court, formal sessions will conclude on July 31st, which is typically the deadline for the legislature to pass major bills. Next slide. Are there any questions? I should pause. Are there any questions on what I just covered?
Emma, I'm really interested in this idea that there would be a primary care spending target. And I don't know if you can give me a little bit of context around that. From all the literature that I'm aware of, the more spending on primary care, the less spending in other more expensive downstream preventable sorts of things. Is this emanating from a need to feel like we need to control primary care spending, or is this emanating from a need that we're underspending in that domain?
I may defer to Lauren on this one if she wants to jump in, but in terms of what the target is, it's a 30% increase over 3 years.
Thank you, because I'm just having a mini panic attack.
Yeah, exactly. It's all about increasing it, but good point, Laura, for sure.
Yeah, and I would just sort of reinforce that this is certainly the latter, which is to encourage and really have our healthcare system make intentional investments and sort of reprioritize, reorient their spending, both for payers and providers, on primary care and behavioral health, for all the reasons that you mentioned, Laura, that those upfront investments pay dividends, long-term, helping keep people out of the hospital and addressing their conditions prior to getting to that acute level. So certainly the latter. And I would say, just as to sort of bring things full circle to your comment, the proposal really envisions this 30% increase spending target within the context of the state's healthcare cost growth benchmark, which essentially means that payers and providers will need to adjust the way that they're sort of tracking and managing their annual increases, so that spending on primary care and behavioral health is really just increasing at a faster clip than other services. But again, within the context and parameters of the overall cost growth benchmark.
Thank you so much for that clarification. I resumed breathing again, so we can proceed.
Good.
Are there any other questions on this slide? All right, Alex, do you mind advancing? Great. I'm now going to pivot to walk through publications that have been released recently, followed by a look ahead to what's coming up next. So since our last meeting, we have released our annual report on the performance of the Massachusetts healthcare system and a report on healthcare equity, both of which you will hear more about later in this meeting. We also released quarterly reports on hospital financial performance and on CHIA's hospital inpatient discharge database. Next slide. Oh, sorry.
I was just saying, could you go back just because I do want to point out, because we often, the annual report and the measurement of total healthcare expenditures, THCE, it's a statutory construct and exercise that inherently involves looking at a calendar year, which for the health plans requires almost a year of run out for them to be able to submit the data to us in a way that they feel is highly reliable. And so there's just a lag associated with the annual report and the THCE exercise that's just unavoidable. But I do want to point out that we have much more recent data available. And so this slide shows that, for instance, the hospital financial data we have through September 30th of 2021. And then in terms of the acute hospitals, the inpatient discharge data, we have quarterly updates. I'm trying to understand the distinction between the two bullets, but essentially very soon, or if not already, we have the December 2021 data posted on our website. So the annual report exercise that we're going to look at is focused on 2020. We have data that's up through about 2 months ago, posted on our website, however, for different aspects of the healthcare system. Okay, here we go.
Laura, did you have a question?
Yes, I wanted to ask Ray, if you, do we have anywhere where we aggregate these? I know that this is mandated to do it on an annual basis. Are we looking at the data over time and being able to get a better view of trends and where we have, I'm certain that what we would see a bit of an outlier in terms of the last couple of years, but do we do anything on our own that pulls those years together in seriatim?
I don't know if we do a formal multi-year analysis, but it's a great point in that we will next year, because I don't think there's any way for us to do a 2020 to 2021 comparison that's just a 1 year to 1 year. And so I think we will inevitably have to compare it in the context of a longer arc. And so I think we will now move from this business of point comparisons to trend comparisons much more so. So we have that data. The HPC, works very heavily with all of this stuff. And so, they're doing more, they do much more than just what we do. And so, but I think that we will be moving more into this trend analysis that you referenced.
I think there's a lot of insights that may be contained in like you said, a more overview over time.
Absolutely.
Next slide, Alex. Perfect, thank you. So in January, we published the first report on our outpatient observation database, which presented key measures of outpatient observation utilization overall and by hospital, patient demographics, and visit characteristics. Also in January, we released our second biennial study on continuous skilled nursing. Lastly, we also continued publishing CHIA's newsletter Data Matters on an every other month cadence and announced the 2021 release of the APCD. So moving ahead to what is coming up in the next few months, this week we will be releasing a report on all payer hospital readmissions, which will have data from state fiscal year 2011 to 2020. Just to note, readmissions are defined as rehospitalizations within 30 days of an inpatient discharge. Additionally, we will be releasing the second report in our healthcare equity series, this time with a focus on geography. This report will provide a baseline assessment of gaps in health insurance coverage, access, utilization, and affordability across 8 health service regions by utilizing 3 waves of the MHIS. Regarding CHIA's reporting on hospitals, we will be releasing FY20 hospital profiles and quarterly updates on hospital financial performance and on the hospital inpatient discharge database, which we were just discussing. We will also be publishing a national healthcare data statistics, which uses several publicly available sources to facilitate comparisons between Massachusetts and the US performance on several key healthcare data points. Also coming up in the next few months is the results from our Massachusetts Employer Survey, a report on provider quality, the next installment of enrollment trends in calendar year 2020 relative price and provider price variation. Additionally, we will be releasing a new mandated benefit review on the psychiatric collaborative care model. Just to note, we are anticipating additional mandated benefit reviews in the coming months as referred to us by the legislature, and we'll be sure to keep the council apprised. And then lastly, coming up are 2 editions of Data Matters. The next edition, which we plan to release next week, will coincide with the publication of the latest quarterly hospital financial performance report and enrollment trends. And that's what we have in terms of publications. I'm happy to answer any questions.
Thank you, Emma.
Thanks, Emma. So as folks can see, just a lot of volume of material. I won't go into length at this meeting. I've talked at prior meetings about how strongly CHIA pivoted to a remote work model and how we increased the pace of a lot of our data collection and publishing activities to increase the focus we could bring on the COVID pandemic. And so what you are seeing in that list of publications, which is there's a lot of work goes into that many publications. It's a reflection of how well CHIA has been doing over the past 2 years. Okay, so I think that's it. And Alex, next slide. Are we ready to? Right, our first presentation is going to be from folks from our research team. I'll let them introduce themselves, but this is a really interesting report. CHIA, as other agencies are, is very interested in taking a closer look at health equity issues in the Commonwealth and seeing what we can do to contribute to solutions. From our perspective, the solutions start with having good data to understand the dimensions of the problem. One of the issues is people often say there's no data on race and ethnicity. That's not quite true. CHIA has different data assets. Some of our data assets do not have race and ethnicity data in it. For instance, our all-payer claims database doesn't, for reasons we can discuss. But our hospital discharge database does. And furthermore, our survey data has race and ethnicity. So when we get to do these very significant 5,000 respondent statewide surveys, we ask, and the gold standard of race and ethnicity reporting is self-reported. So we ask people their race and ethnicity. So we have that data in our health equity report. The issue has been it's hard to slice and dice by more than one socio-demographic variable with a 5,000 person survey. So we could often report on minority groups, but we couldn't report on income and minority status and other things like that, trying to combine demographic variables. So what we've done and what the team will tell you about is we've actually done some sophisticated work to combine multiple surveys so that we have larger sample sizes so we can do more multivariable analyses of these health equity issues. So very interesting and important stuff. The CHIA's research team has done really good work in pulling this together. And as you heard Emma just mention, there's a part 2 to this that we'll be releasing in June and reporting on at our June meeting that looks at these same health equity issues in terms of access to care, affordability, and so on, but not through the lens of demographic characteristics, but through the lens of geography, which is a different way of looking at health equity issues. So really, really good stuff. But with that, I'm going to turn it over to Hong Tru, who is Senior Director of Research at CHIA, and she and Amy will walk you through the report.
Hello, thank you for that introduction, Ray. Good morning to members of the council. As Ray mentioned, my name is Hong Tru, Senior Director in CHIA Strategy and Research Unit. And with me here today is Amy DeSantis, our Senior Researcher. And today we will be sharing with you some of the key findings within the reporting series on healthcare equity. Next slide. I think to begin with, I think I do want to focus a little bit on why healthcare equity now. I think everybody kind of know that the evidence on the disparate effects on the COVID-19 on the community of colors where they have higher COVID-19 infection rates, hospitalization rate, and mortality rates than white communities, has created this urgency to address healthcare equities. And while these inequities are not unique to the healthcare system, they are reflected in persistent health disparity and increased disease burden for community of colors and other marginalized population, and is well documented nationally. So here in Massachusetts, while we continue to have very high rates of health insurance coverage, strong access to and use of healthcare, in part due to implementation of the key components of the ACA, which builds on our state's 2006 healthcare reform, healthcare gaps do persist among different populations, that's including but not limited to residents of different racial, ethnic backgrounds, national origin, socioeconomic level, geographic region, as well as disability status. So as I mentioned earlier, it is imperative that we do have some information that's reliable and meaningful to present on the subpopulation to inform policymakers, healthcare providers, payers, other stakeholders in the state. Next slide. And to do this, as Emma and Ray also mentioned earlier, CHIA has launched a new reporting series that systematically look at these issues of healthcare equity in the Commonwealth. And we do that beginning with this baseline assessment on the gaps in health insurance coverage, access, utilization, and affordability in the periods leading up to the COVID-19 pandemic. The first chart book focuses on race, ethnicity, and income, and it was released in December of last year. And the second chart book is focused on geographic region and is forthcoming next month. Next slide. And so for this presentation, we will be highlighting some of the key findings from our first chart book that I just mentioned, and we are focusing on the race, ethnicity, and income findings. Next slide. So to begin with, I just want to share with you what Ray had mentioned, that the data source for this reporting series is based on our Massachusetts Health Insurance Survey, the MHIS. And the MHIS is an ongoing population survey of Massachusetts residents about their healthcare experiences. CHIA and its predecessor agency have conducted the MHIS intermittently since 1998. And right now on a biannual basis in odd number years since 2015. So topics that we cover in the survey includes health insurance coverage, the use of healthcare services and barriers to accessing care, the changing landscape of healthcare affordability in the Commonwealth. And we have also added questions on social determinants of health and more in-depth questions on behavioral health since the 2019 cycle. And for this healthcare equity report, as Ray have mentioned earlier, we are using a new multi-year data assets that we are combining the MHIS data across 3 biannual waves, so 2015, 2017, and 2019, and covering a 5-year period. And it's really about that certain subpopulation, including in the analysis that we are interested, have relatively small sample sizes in each survey cycle. And the data, when aggregated across the 3 waves, will increase the robustness of our estimates for the population we want to study. Next slide. So with this, I'm going to pass it over to Amy to go over some of the domains and measures that's analyzed in our first chart book, as well as key highlights.
Thank you, Hong. So for this first chart book, the specific domains that we focused on for the report were health insurance coverage and healthcare access, utilization, and affordability. So for health insurance coverage, we focused on differences in the percentage of residents within specific subpopulations of interest who had continuous health insurance coverage for the 12 months prior to the survey. We next analyzed differences in access to healthcare services, which we assessed by the rates of difficulty finding a provider accepting new patients, difficulty finding a provider who accepts the resident's insurance type or uninsured patients, and difficulties getting an appointment as soon as the resident felt one was needed. We also created a single variable to indicate whether a resident had experienced at least one of those 3 types of access difficulties, and that summary variable is the one that we'll focus on here. We also investigated differences in the rates of healthcare utilization, which was assessed based on whether a resident has had a visit with a doctor in the past 12 months, whether the resident had a visit with a dental provider in the past 12 months, or whether the resident has a potential reliance on the emergency department, specifically meaning that they had 3 or more visits to the ER in the past 12 months, or reporting that their most recent visit was for a non-emergency. Finally, we analyzed differences in rates of experiencing affordability challenges. For this domain, we had one variable to indicate whether residents had either family medical debt or problems paying individual or family medical bills, and a second variable to indicate whether residents had experienced any unmet healthcare needs due to cost, including prescription refills or visits to a general doctor or a specialist or a mental health provider or a dental care provider. Next slide, please. So for health insurance coverage, the percentage of residents with coverage all year in the Commonwealth overall was 93.3%, but this differed across racial, ethnic groups and family income level. Overall, the rates of continuous insurance coverage for the past 12 months were lower for Hispanic and non-Hispanic Black residents compared to non-Hispanic white residents. And within each racial and ethnic group, the rates of insurance were lowest among residents in the lowest 2 income categories. So below 139% of the federal poverty level, shown in the light blue bars, or between 139 to 300% of the federal poverty level, shown in the medium blue colors on these bars. It should also be noted that the highest 2 income groups, 300% of the federal poverty level and 400% of the poverty level, were combined to make the sample sizes larger, and that even though they represent the highest income level group in these analyses, the actual absolute level of income is not very high. And the middle income group, for example, the families ranging from 139% to 300% of the federal poverty level have incomes ranging from $17,236 to $37,470 for a family of 1, or $35,535 to $77,250 for a family of 4, which is not exceptionally high in Massachusetts. So that calling them the middle group is not meant to imply that they're, quote, middle class by typical standards in the Commonwealth. Next slide, please. So when we look at access issues, we find that overall, 27.9% of all Massachusetts residents experienced at least one difficulty accessing healthcare at a doctor's office or clinic within the past 12 months. Again, as a reminder, we assessed access difficulties by the rates of difficulties with access to care based on difficulty finding a provider accepting new patients, difficulty having your insurance accepted or being uninsured, and difficulties getting an appointment as soon as you felt one was needed. This challenge was most severe for Hispanic residents, shown in this chart in the aqua blue on the right, with 35.2% reporting one or more of these access difficulties, compared to 26.2% of non-Hispanic white residents, who are shown in the dark gray on the left. Next slide, please. Although there were racial and ethnic differences in the rates of experiencing difficulties with healthcare access, overall, they were even more pronounced among residents with family incomes in the middle range of our analyses. So between 139% to less than 300% of the federal poverty level. So that would be the 4 bars in the middle of this graph. In this group, 39.3% of Hispanic residents reported difficulties accessing care at a doctor's office or clinic, compared with 29.6% of non-Hispanic white residents. And it should be noted that in this middle group, these are the people who would maybe have incomes too high to qualify for some of the income-based safety net programs that have lower eligibility limits, but not quite high enough to access care using their own independent means. So it's a group that kind of might fall in between the safety net and being wealthy enough to pay on their own.
Amy, that leads me to 2 questions. One, I just don't remember, what is the limit for Mass Health to be eligible?
Oh,
100 and... Somebody must
No.
know. Oh.
I don't know off the top if it's, do you know if it's
Does anybody?
I feel
Somebody?
like it's somewhere between 100 to 200, but I don't want to say the wrong thing.
I think that mass health eligibility also varies by some condition that you may have as well. But I think just off the top of my head, I'm pretty sure the less than 139% of PL is covered under mass health. But I think there are some categories like HIV treatment, or if you're pregnant, will be covered under a higher threshold. And I don't have that off the top of my head, but we could definitely get you that information.
No, just thinking about it actually in the eligibility and people who are covered question. Only because I ran into a very odd situation once where people said, no, I don't have health insurance, I have mass health. Okay, but you're supposed to say, yes, you're covered. My second question is, when you said difficulty accessing care to the doctor's office, is this both physicians and dentists?
This is for general doctor or specialist, but not for the dentist.
Okay.
There are questions about dental visits and doctor visits that are in a separate part of the analyses, but this is for general doctor or
Okay, so this is just for MDs.
Yeah.
Basically. Got it. Thank you.
Sure, you're welcome. Okay. To the next slide, please. Thank you. So for the utilization analyses, we found that overall, 14% of all residents had a potential reliance on the ER for care. Again, as a reminder, we assess potential reliance on the ER as having at least 3 or more visits within the past 12 months, or reporting that the most recent visit to the ER was for a non-emergency. Notably, at each family income level, Hispanic residents were more likely than non-Hispanic white residents to have a potential reliance on the ER. And specifically, Hispanic residents with family income below 139% of the federal poverty level, shown in the aqua blue bar on top, were 1.5 times more likely than non-Hispanic white residents to have a potential of reliance on the ER. Next slide, please. Okay, so next we looked at doctor visits. So again, this is MDs, not dental care, which we do have but aren't presented today for the sake of time. We find that overall, 88.9% of all Massachusetts residents had a visit with a general doctor or specialist within the past 12 months. However, members of racial or ethnic minority groups had lower rates of doctor visits overall compared with non-Hispanic white residents. Moreover, among non-Hispanic white and non-Hispanic Black residents, those with the lowest family incomes, so the lightest shade of blue for each racial and ethnic group, were less likely to have a doctor visit in the past 12 months compared to their same race counterparts with higher family income. And then among Hispanics, shown in the bottom set of bars, rates of doctor visits did not differ significantly by family income level, but you see that at each income level, they're generally lower overall. So the highest income Hispanics had lower rates of visits than the lowest income non-Hispanic whites. Next slide, please. Okay, so we next looked at affordability issues, starting with the question of medical debt or problems paying medical bills in the family. And we find that overall, 22% of residents in the Commonwealth reported having medical debt or problem bills in the family. Once again, racial and ethnic minority residents were more likely to experience medical debt or problem bills in the family in general, overall, which is not shown here. But what is shown here indicates that for residents in every racial and ethnic group, the highest rate of medical debt or problems paying medical bills in the family were among residents with family incomes between 139% to 300% of the federal poverty level. Notably, this is the group who might have income, again, too high to qualify for some of the public safety net programs, but too low to pay for expensive medical costs in a timely fashion. Next slide, please. We next looked at unmet healthcare needs due to cost. And we find that overall, nearly a quarter of Massachusetts residents, or 24%, reported having at least one unmet healthcare need due to cost. Again, racial and ethnic minorities were more likely to experience unmet healthcare needs compared with non-Hispanic whites as a whole. And more specifically, among residents at or above 300% of the federal poverty level, so shown in the bottom set of graphs, Hispanic residents in aqua blue were 1.5 times more likely to report unmet healthcare needs due to cost than were non-Hispanic white residents, shown in the bottom gray bar. Next slide, please.
Sorry. Quick question.
Sure.
Do we know like a sense of like the scale of that kind of like group that we're discussing, kind of like that group that might have too high of an income to have benefits, but not enough to afford healthcare?
So the scale, you mean like the absolute numbers?
Or like, yeah, or even like like how many people are we talking about?
That is a good question. I think in our chart book, we did translate some of these percentages to absolute numbers. I'm not positive about that one, but I could definitely get back to you on that. This is a trend we noticed. You might have seen, in both access and unmet healthcare needs, that the middle income group was, sorry, I meant the affordability, problem bills and medical debt and access issues, that this middle group is the one that seemed to have the most difficulty. And I can definitely translate that into numbers based on the number of people we have in those groups. But I don't know off the top of my head what those would be.
Oh yeah, no worries. Thank you. I appreciate it.
Sure.
I will say this is an area that where our data is, the connector authority is sort of a power consumer of CHIA's survey data, and it's for exactly this reason. They're very interested in the characteristics of people that have access or affordability or coverage issues. And so I know they could tell you right off the top of their head, because this is really their kind of subject matter area. This is an example of where we collect sort of the baseline or the foundational statistics, and very often it's other organizations that really put it to programmatic use. So I do know that the people that are just outside of that mass health eligibility band, those are the people that are the natural constituents for the connector authority. So there are state programs and people that are very focused on that. And we could probably check it out, during the annual report part of today's presentation, have a number for you. But sort of we're just kind of the first pass, and then there's the specialists, which in this case would be the connector authorities, really interested in these populations.
Yeah, no, definitely, Ray. Totally makes sense. Yeah, thank you.
Thank you, Ray. Yes, we will get back to you on that, though.
And Amy,
yeah.
Do we have the capacity to geolocate? Or I know we do aggregate data, but do we have the ability to understand where these gaps are the greatest in the state, just geographically?
That is the next chart book, actually. Will be focused on geography. So yes, we will be focused on that next, looking at the health service regions, and as well as, so those are the large 8 regions, but we're hoping to delve even deeper in the future, looking at even more specific geocoded data, and eventually even combine this with some of the patient data. But this is really the first pass at an overall picture of some of the racial, ethnic, and socioeconomic differences. But next we will do the larger geography analyses, and then more detailed geographic analyses. I should also mention one of our analysts is starting to look more in depth at some of the reasons for the racial and ethnic gaps in the ED use that seem to be the largest. So with Hispanics having 3 times the rate of ED use for non-emergencies, and African Americans twice as likely. So we're running multivariate analyses of those right now, and we're looking at a number of different factors that might explain that. This is just really the first pass at a bivariate analysis, or in some cases 3-way analyses, but that's definitely next on the agenda.
Happy to hear that's on the horizon. I'm just seeing more and more of a trend toward hyperlocal data, data sharing, hyperlocal analysis, and even as it might shed light on the next pandemic or the next opportunity to sort of extrapolate, even if we don't have extraordinarily current data, maybe down to the zip code, we would at least know where to concentrate some resources more than we have in the past.
Yes, great.
Right, well, and on that topic, I'm sorry, Amy.
Oh, sure. I was going to shift back to just say that thank you to Emma for sending me a note in the chat from our technical appendix, which I should have had open, that the percentage of people between 139 to 300% of the FPL is 12.7% of the population, or 863,000 people. So thank you, Emma.
And I did want to say that the issue of geographic analysis, Laura, as Amy just said, this exact framework of coverage, access, utilization, and affordability, in June, we're going to lay that out by how that varies across the state geographically, but by large geographic units, kind of the 8 health service areas that Health and Human Services uses. Separately, we're exploring the idea of we want to collect, just as we measure expenditure information very, very carefully in the state, we've historically never been more granular than 5-digit zip code. We've now asked the health plans what it would take to measure, because they report to us, every health plan as part of this annual report exercise you're about to see, reports their spending to us. They break their spending down by service category, hospital inpatient, hospital outpatient, physician services, and so on. They also give it to us by 5-digit zip code. So we can show you how spending varies across the state at the 5-digit zip code level. We've asked them if they can go to the census block group level. This was the Attorney General had a report that recommended this, and so we're trying to move forward on that. The health plans have been very resistant to the idea of doing it in this current round of data collection that we're going to do this year. So we're always sort of happy to listen to our data submitters and understanding what's possible, but this idea isn't going away. And so we're discussing with them sort of how soon it would be practical for us to start measuring spending in the state at the census block group level, which would be exquisitely detailed, looking at and able to link to lots of sociodemographic data from the Census Department. So that would really be a huge win when we can get to that point.
I find that so exciting because in talking with a colleague from Cincinnati, they were talking about they felt helpless during the pandemic because they had all these resources with mobile vans for testing and vaccination and didn't know where to direct their mobile vans. They just didn't know where the greatest need was.
Oh, fascinating point. Great point.
And to add, I think for our next cycle, right now, the 2021, we are asking census block group information to be added to the survey as well, because I think the geography analysis that we will be reporting on for the 8 region is aggregated from the zip code level. So I think in the future, we will also have more detailed localities, even within our surveys.
It'll be interesting to see how much resistance we encounter to something like that. It is interesting that part of the conversation with my colleague from Cincinnati was that there was resistance to the census block, to understanding exact neighborhoods and things like that. So it's probably not going to be free sailing to get there.
I had one quick question. Does the MHIS ask about income in a way that is more granular than what's represented here? I'm thinking in particular about the Ray's comments about the connector and their interest in this data, and wondering if there's the option of looking at folks between 300 and 350 or 300 and 400% of the federal poverty line, folks who are kind of just above the income threshold to qualify for connector care plans, or whether that's even possible with this data set.
I think
We
in the
do
way,
start. Oh, Tom, you can answer.
jump in. But the way we ask the survey consistently on income is that we do ask them, so what is your income? And then if they don't answer, because that income is usually in surveys the most missing of any variable usually. So on average, you will have about 10% of missing data on that, 10 to 15% overall on that variable. So the way we ask in the MHIS, we do ask them, so what is your income? And if they refuse or they're silent, then they're prompted to so what is the range? Would it be above this, below this? So they are prompted, but the category that we kind of prompt them is at, so we would be is it up, give them a much bigger bracket first, and then we kind of narrow down on the FPL levels that's from the federal poverty line. So we asked, I want to say 10 buckets, and from there, that's where that comes. So I will have to look back right now in the respondent to see how many people did provide a number of their income versus they're willing to tell us what bracket they fall under. So Amy, you were going to say?
Yes, we definitely do. We have the, as Hong said, that we try and get the exact number, and then failing that, we have 10 different buckets that we're in, which are much more precise than this. 300 plus that we have. I should also say, in our initial bivariate analyses here, we do have 300% and 400%, separated. We only combine them specifically when we look at race by income to make the sample size larger, but we do, have those separated in the overall analyses, and we could, in theory, look at them separately.
Got it. Thank you.
Very welcome. Yeah, so I'll just, recap the summary. Overall, we find that in the Commonwealth, racial and ethnic minority, as well as lower income residents, had lower rates of continuous health insurance coverage and doctor visits, and higher rates of difficulties accessing healthcare and medical debt or problem bills compared with non-Hispanic whites and higher income residents, respectively. With respect to coverage, racial and ethnic minority residents were less likely than non-Hispanic white residents to have continuous coverage all year, with differences that were especially prominent for residents in the lower family income brackets. For healthcare access, we found, again, racial ethnic differences in accessing healthcare at a doctor's office or clinic were most prominent among residents in the middle income groups rather than the lowest, again, suggesting that some of the safety net programs targeting the lowest income families may help, but leave those just above the cutoff left behind. In terms of utilization, we find that regardless of family income, Hispanic residents are more likely than non-Hispanic white residents to have a potential reliance on the ER over the past 12 months. And among non-Hispanic white and non-Hispanic Black residents, those in the lowest family income bracket were less likely to have a doctor visit in the past 12 months than their same race counterparts with higher family incomes. Finally, when we looked at affordability challenges, we find that for residents of every racial and ethnic group, the highest rate of medical debt or problem bills in their families were found among residents with family incomes between 139% to 300% of the federal poverty level, mirroring the findings we had for access challenges. And again, suggesting that some of the safety net programs may leave those just above the eligibility cutoff limits, struggling with either medical debt or problem bills. And lastly, among residents at or above 300% of the federal poverty level, again, not exceptionally high, but the highest level in our analyses, Hispanic residents were 1.5 times more likely to report at least one unmet healthcare need due to cost than non-Hispanic white residents at the same income level. And so next slide, please. Sorry, so now I will pass it back to Han to discuss a little of what's next.
Oh, thank you, Amy. And I want to address that. I think Meredith kind of had a question about what is the share of the middle income group that has employer sponsor insurance. I think we did an initial look on it, and we can get proportion to you if you're interested. But I think by and large, for surveys, like they have mentioned, some people don't realize they have kind of like a mass health, or they don't realize they have employer sponsor insurance because of a variety of reasons. So the self-reported kind of like payer type is not as reliable from surveys, and hence we haven't kind of present a lot of analysis on that. So with that, I will go over a little bit about what's next for us. As mentioned earlier, we are definitely going to be publishing our second healthcare equity report on geography that's coming out next month. And as Amy has mentioned, we are looking into some new in-depth analysis, really saying controlling for all these other indicators in terms of utilization, payer type, and such, to really look at what is the impact of racial ethnic factors, on access and affordability, as well as a potential reliance on the ER. And we're looking to sharing those results with you in the future. It's very exciting for us is that, as I mentioned earlier, we will be having new data from the 2021 MHIS cycle, and that will obviously be covering our coverage, access, use, and affordability. But as well, this would be the first survey cycle since the beginning of the pandemic. So new topics will obviously be including what is the COVID impact on these 4 domains, as well as what is the use of telehealth services. And we have also expanded our module on social determinants of health. And in this cycle will include topics of food security, housing, health literacy, as well as other issues. And we look forward to sharing those results and summary findings with you in the near future. Next slide. And with that, thank you so much for your time, and we're happy to answer any additional questions you may have.
Thank you. I think it's great work and lots of, now even 15 more questions to really dig into. Questions from council members? Anything in particular, as certainly as they're moving forward in the next research cycle?
Just want to add a note of gratitude for this work and for your focus on health equity and really mining this data to help illuminate some of these very persistent disparities that we know and see. And so we are also, as you know, power users of the survey work and incorporate it into our policy analysis. And so just a note of support and gratitude, and excited to see where this goes next. Thank you.
Thank you.
Thank you, David.
Thank you. We look forward to it also.
Great. Anybody else? Terrific. Okay. The annual report on the Mass Healthcare System.
All right, I'm going to just turn this straight. I mean, this is a lot, and we really welcome this being as highly interactive as that last discussion was. And so please pitch in. I said with a particular eye towards what are the follow-on questions or analyses that this suggests to you. Once again, the data itself is quite extraordinary, so we think it's probably less about looking at 1 year of data and more about pulling the lens back and looking at multiple years. But first, you have to start with seeing the 2020 data. So that's what you're about to see. And who am I handing it to first? Is it you, Molly?
Yep, it's me. Thanks, Ray.
Excellent. There you go. Thanks.
All right, great. So we'll jump right into the background slide. So every year since 2013, CHIA has published an annual report, which includes data on health expenditures, quality of care, premiums, cost sharing, etc. And this year, to assess the full picture of the impact of COVID-19 on the healthcare system, we added chapters on hospital and nursing home utilization and finances. The annual report also includes total healthcare expenditures, known as THCE, which is measured against the healthcare cost growth benchmark on a per capita basis. So diving into THC on the next slide, we'll see that total healthcare expenditures declined from $63 billion in 2019 to $62.6 billion in 2020, coming to $8,912 per capita. This puts the per capita growth rate at negative 2.4%, which is well below the healthcare cost growth benchmark. This decrease in THC was driven by declines in aggregate commercial spending at negative 4.5% and Medicare spending at negative 3.4%. The decline in commercial was associated with a 2.1% enrollment decrease, whereas Medicare enrollment actually increased 1.1%. Mass health spending increased 3.2% due to enrollment growth from federal mandates for continuous coverage and $495 million in new COVID supplemental payments in 2020. Other public programs, which include spending for the Veterans Administration and Health Safety Net, increased 7.3%. NCPHI, which is the net cost of private health insurance, represents the administrative costs of providing health insurance, or can also be thought of as the funds left over after paying for medical claims, increased 31.2%. Christine is going to dive into this a little later on, but this was due to 2020 premiums being set in advance of the pandemic using historical data and the unanticipated drop in utilization and COVID's impact on insurer expenditures. So it's important to note that while these totals include the Mass Health COVID payments, they do not include any federal funding related to COVID-19, like the Paycheck Protection Program and CARES Act. We did not include these payments as they were distributed on a fiscal year basis and not a calendar year basis on which THC is assessed. And for THC, we really follow and focus on the payer-provider relationship and that flow of funds. The hospital and nursing home chapters to be discussed later include the federal funding dollars and show the impact of these funds on bottom lines. So on the next slide, we're looking at program drivers of the 3.2% mass health spending increase. So with this spending increase, overall mass health enrollment increased 4.5%. There were membership increases in all program types except for the primary care clinician plan, the PCC plan. With the enrollment increases, spending for the dual eligible programs increased 6.8%. ACOB or primary care ACO spending increased 5.4%, and fee-for-service spending decreased 6.2%. The supplemental payments category increased 43% from 2019 to 2020. This was largely driven by the $495 million in new COVID supplemental payments, but also by increases in existing supplemental payment programs, including the Behavioral Health Quality Incentive and Safety Net Provider Payment programs. So next we see the decline in THCE broken down by service category, so we see that the decline was largely driven by decreases in hospital outpatient at negative 11.1% and physician spending at negative 12%. This was expected due to directives for hospitals and ambulatory surgical centers to postpone or cancel non-essential elective invasive procedures during the COVID state of emergency. Hospital inpatient spending also decreased 1.8%, as did other medical, which includes services like durable medical equipment and transportation at negative 2.1%, and other professional, which includes services by non-MD providers like nurse practitioners, physical therapists, et cetera, at negative 1.5%. So if we did include the federal funding, the COVID federal funding to calendar year 2020, hospital inpatient and outpatient spending combined would have increased 1.9%, and physician spending would still have decreased, but slightly slower at negative 10%. On the other hand, pharmacy and non-claim spending both accelerated in 2020. Pharmacy spending gross of rebates increased 8.2%, faster than the 6.9% the prior year. This faster trend may be due to the shift to 90-day prescriptions instead of the typical 30 during the pandemic, the ease of using telehealth for prescribing, and increased drug prices. Non-claims spending increased the fastest at 28.8%, driven by the Mass Health COVID payments and also increases in risk settlements and other non-claims payments related to provider contracts. So the next slide looks the same as the previous, except it's showing pharmacy spending as net of rebates. So net of prescription drug rebates, pharmacy spending increased 7.7%, faster than in previous years and actually converging with the gross trend. Massachusetts net of rebates trend was faster than the national trend for 2020, which was 3% as reported by the Centers for Medicare and Medicaid Services. The accelerated net trend was due to slowed rebate growth in 2020. In 2019, rebates increased 23.8%, while in 2020, rebates only increased 9.9%. This slowed rebate growth was largely seen in the public payer sectors, especially the Medicare standalone Part D plans and the Medicaid managed populations. So for the next two slides, we're going to look at total medical expenses, or TME, on the next slide, which is different than THCE. These next two slides are only looking at the commercial full population and do not include any adjustments. These are the 2019 to 2020 final trends. So this first slide shows unadjusted per member per month growth. And we see that all payers come in under the 3.1% benchmark, with all but Aetna reporting negative per member per month trends. The next slide shows health status adjusted per member per month growth for the commercial payers, which is the metric on which we refer payers and providers that exceed the 3.1 benchmark to the HPC. Here we see a different picture than the unadjusted trends, with most payers reporting positive HSA TME growth, with 3 coming in over the benchmark. The HSA TME trends differ so much from the unadjusted because in 2020, aggregate risk scores declined, which payers cited was due to decreased utilization resulting in fewer inputs into their risk tools. We intend to do further analyses of adjusted, unadjusted, and risk score trends in the coming months to see how these changed over time and their comparison in non-anomalous years. So if there are no questions on anything THC or TME related at this time, I'm going to turn it over to Brian Danner to discuss key findings from the quality section of the report.
Yeah. Any questions from council members? There's a lot, fast. Okay.
Okay, thank you, Molly. So for this year's quality measures are based on Hedis scores. Hedis stands for the Healthcare Effectiveness Data and Information Set, which measures health plan performance based on measurements of clinical care. While the National Committee for Quality Assurance reports numerous measures grouped into 6 different categories. CHIA will be reporting on a subset of the overall Hedis measurements. Hedis measurements rank. In 2020, the displayed Hedis measures for behavioral health have increased from 2018, while the displayed measures for screening and prevention shows a decrease from 2018 to 2020. These trends may have been influenced by the increased telehealth visits during the pandemic of 2020. And in the coming months, CHIA will be reporting or expanding on the number of Hedis measures that will be explored. Now I'll pass it over to Christine Chung if there are no questions for equality.
Yeah, it was.
Thank you, Brian.
Thank you, Brian. Do I understand this correctly then, that behavioral health looked pretty good?
Yes, so from what we're able to see, behavioral health actually showed an increase from 2018 to 2020, while screening and prevention showed a little bit of a decrease from 2018 to 2020.
Which I think most would have been shocked if it hadn't.
Exactly. This, yeah, sort of, but it's also good to have sort of the data confirming our suspicions that, right, things that required physical presence and these are process measures. So they're not saying that behavioral health outcomes were better during the pandemic. In fact, I think we have every reason to believe that's not the case. But what this shows is that screenings, kind of the process aspects of care delivery were improved because of the prevalence of telehealth. You would assume in the case of behavioral health. So and worse in the case of in-person things that require in-person screenings. So this is something we're going to keep looking at. Particularly, it would be really great to see improved scores in the behavioral health category because of telehealth, but we'll keep monitoring this.
Great, thank you.
Thank you, Brian.
Thank you.
Next
And
slide,
then
please.
the next slide will go over private commercial insurance with Christine Chung.
Thanks. So moving on to affordability in the commercial market, member cost sharing, which includes copays, coinsurance, and deductibles, fell 17.2% to $49 per member per month in 2020. This unprecedented decrease was experienced in all market sectors, driven by the decrease in healthcare utilization due to the pandemic. Additionally, in 2020, policies that eliminated cost sharing for specific services were implemented. For example, the Division for Insurance mandated that payers waive cost sharing for coronavirus testing and treatment. And some payers also voluntarily waived copays for other services, such as telehealth visits for behavioral health services and PCP appointments. In line with trends in prior years, average cost sharing for members covered through larger employers were lower. And this is related to the differences in high deductible health plan adoption across different market sectors. Next slide. In 2020, 38.6% of commercial members were enrolled in high deductible health plans, which is defined as individual deductible levels of at least $1,400. More than 63% of members enrolled through smaller employers, and 82.8% of unsubsidized individual purchasers were under high deductible health plans in 2020. Despite overall enrollment declines, high deductible health plan enrollment grew for all market sectors, which presents continued potential affordability concerns as utilization returns to normal levels. Next slide. Continuing to look at affordability, fully insured premiums increased by 2.6% to $529 per member per month in 2020, after increasing 2.3% in the prior year. And this followed higher premium growths of 4.8% in 2017 and 5.7% in 2018. It should be noted that premiums for 2020 were developed in advance using historical spending data and without knowledge of effects of the pandemic, which explains the disconnect between the premiums and healthcare spending trends. However, some payers issued premium refunds or credits to account for this unexpectedly low utilization, and the numbers shown already reflects those credits as well as MLR rebate amounts. Next slide. Now we'll shift the focus on how these premium funds were spent. So the pie chart to the left represents premiums per member per month. The gray portion reflects medical claims costs, And the blue portion represents non-medical expenses and surplus, which is essentially funds that remained after payers covered medical claims. Previously, this was referred to as premium retention and includes things like administration costs, broker commissions, taxes, and net gains, which are shown in the stacked bars. And this metric grew 35.4% from $62 per member per month in 2019 to $85 per member per month in 2020. While all other components remained relatively stable, taxes and fees grew from $5 to $12 per member per month, and net gains or surplus grew from $4 to $19 per member per month in 2020. And this increase in net gains or surplus was driven by lower utilization due to the pandemic. However, medical loss ratio requirements serve as guardrails to keep health plan administrative costs in check. In 2020, there were increases in the number of Massachusetts members who qualified for MLR rebates and in the average rebate amount, which was $117 per qualifying member in 2020. And because the federal MLR formula considers a rolling 3-year period, the plan's experiences in 2020 will continue to impact the 2021 and 2022 rebate amounts. And if there are no questions so far, we'll turn it over to Brian to discuss hospital trends.
So can I ask about taxes? What changed between 19 and 20 for taxes?
I think Ashley might be better able to explain that.
It's a big, I mean, they're both, one I understand, but the 5 to 12 seems like a big leap, or the 5 was the odd one.
Yeah, the 5 was the odd one in this case. So there are certain ACA related premium taxes and fees that Congress has decided in some years to collect, and in other years they've been written in and out of various bills. And so that's why it's bounced back and forth over the past several years.
Okay,
so totally outside of the control of Massachusetts.
Yeah, thank you.
Thanks, Ashley.
All right, thank you. So the next couple of slides are going to focus on acute care hospital utilization reported from our case mix data. And some of the data we're using reported includes data from federal fiscal year 2021 or 2020 and 2021, which includes more data beyond what might be reported elsewhere in the report. So here we are seeing the total acute care hospital inpatient discharges by month reported from October 2018 to September 2021. So prior to the COVID-19 pandemic, total acute care hospital inpatient discharges were relatively stable between October 2018 and December 2019. And then there was an observed drop in the total number of inpatient discharges between January 2020 and April 2020, coinciding with the rise in COVID-19 cases we saw in Massachusetts in spring 2020. So then total patient volume partially rebounded by June 2020, but then dropped again to a new low in February 2021, coinciding with the second wave of COVID-19 cases we saw in winter of 2021. These drops in inpatient volume are mainly attributable to a decrease in the number of adult non-obstetric discharges, particularly for planned admissions for procedures such as hip and knee replacements. This timing is consistent with directives to postpone non-essential elective procedures during peak periods of COVID cases in the Commonwealth, and those periods are highlighted in gray on the chart. So this next chart, what you're saying is the number of emergency department visits from acute care hospitals, specifically the treat and release, meaning that this is emergency room visits that did not result in an inpatient admission or observation. And we see very similar trends to the inpatient hospital chart, where utilization was very relatively consistent before the pandemic, and then dropped at the during the initial rise of COVID-19 cases in spring 2020, rebounded a little bit, then reached another new minimum in the second wave of COVID cases in winter of 2021. Next slide. This chart is showing the number of acute care hospital inpatient discharges related to COVID-19, and then it is broken down by the expected primary payer type as reported by the hospital. So we see in dark blue, that is expected primary payer type of Medicare, and light blue is Medicaid, and in dark gray is commercial insurance. So we see that there is a high number of hospitalizations due to associated with COVID-19 during those peak COVID months, including spring 2020, as well as winter 2021. And some of the things to note here is that prior to the COVID-19 pandemic, discharges for patients with Medicare as their primary expected payer type typically made up a little under half of the total inpatient volume. Among inpatient discharges associated with diagnosis of COVID-19, discharges for patients with Medicare as expected primary payer type may have a higher share of inpatient discharges compared to non-COVID related inpatient discharges, made up over half of all the inpatient discharges. This is consistent with the expectation that a lot of the COVID inpatient hospitalizations were associated with COVID were among those who are older, who are more likely to be on Medicare.
It also just shows you how extraordinarily bad those couple of months were. I mean, 9,427 and just really were those highs are really quite high compared to, kind of the background numbers. So, all right, thank you.
So does it make just as clarification? So I'm assuming that the 700, 800 range would be a normal month. Or not? I'm trying to calibrate how high is.
Right. Well, in terms of it's a pandemic, so there's it's hard to say what the normal, but it does show that many months are down, under 2,000 or even well under, but there's a couple there where it was, 7 to 9,000. So just showing that there's a few really extraordinary months there.
Okay. Mm-hmm. Okay. And this is just related to COVID. I recall somewhere a definition of, is this a COVID patient or is this somebody who came in with something else and had COVID, and how that plays out and it's changing. So which is it for this data?
So this data is reported to us by the acute care hospitals, and patients were identified as being associated with COVID-19 is if they had a medical diagnosis, whether it's primary or secondary, of COVID-19 listed on the discharge.
Okay, thank you. Other questions from the, I have to keep looking at everybody. Nope.
Good. There's no more questions. I'll pass it off to
Brian, I know we had have an adjustment for diagnoses that were that had COVID associated with them or discharges with COVID. Are we going to be adjusting the data accordingly?
Sorry, can you repeat the question again, sorry?
When we looked at the number of COVID cases in the state, I know that we've recently made a significant adjustment that just because you had COVID associated with your discharge diagnosis doesn't mean that you were in the hospital because of COVID. You were in and you tested positive, but you were in for something else.
Yes.
Will we be doing some retrospective look at our data?
So it is my understanding, unfortunately, we do not have the exact date of diagnosis of COVID on the discharge of the information reported by a hospital. We simply have the information of the diagnoses that was provided on the patient's clinical record as reported to us by the hospital.
I thought it might be too complicated to go back and tease that out. Thank you.
That's a good question. I was reading about that, like trying to changes in the definition of the COVID-19, especially related to the COVID deaths. But this one specifically is whatever is reported on the hospital record is what is reported to the case notes.
Yeah. Thank you.
Right. There's no more questions. I'll pass it off for Jim.
Thanks, Brian. So I'm going to talk about some hospital financial trends we saw in the past year. I'm going to start with total and operating margin trends by hospital cohort. So on the right here, we have
actually, Richard, if I could, my apologies, if I could just interject before you start. This chapter where you're about to see, well, and there's much more in the report itself, but this is not something that we had traditionally included in the annual report, which was just a focus on total healthcare expenditures and some of the aspects of commercial insurance coverage. But because of the extraordinary events of 2020 and the fact that the hospitals were really front and center in response to the pandemic, we felt it would just be very incomplete to present the 2020 annual report without also addressing the issue of hospital finances. And so separately from the whole THCE exercise, CHIA is the primary collector of hospital financial data. So we leveraged that fact to broaden the annual report. And so now Richard's going to share some of our findings with you. There you go, Richard. Sorry about that.
No problem. Thank you. Yeah, so we have operating margin trends on the right here, and then we have total margin trends on the left. Total margin is comprised of both operating margin and non-operating margin, such as investment income. And each cohort here is a separate color line. And the statewide median is the dashed darkest gray color line. So you'll see from 2019 to 2020, both the total margin and the operating margin saw a decrease at our hospitals, although both those numbers remain positive. Now, these numbers do include COVID relief funds. If we go to the next slide, I'll jump into how those relief funds affected these numbers. Go to the next slide, please. Okay, so here we have in the aggregate, the operating revenue side of things for all hospitals. So the blue stacked bars are revenue, and the thinner gray bar to the right is expenses. The darkest shade of blue is net patient service revenue. So that's revenue from providing patient care. You'll see from 2018 to 2019, NPSR increases, and then from 2019 to 2020, the net patient service revenue decreases. And in 2018 and 2019, the total revenues exceeded total expenses. And in 2020, that was again the case, but only because of COVID-19 relief funds. So the top two sections of that revenues bar graph there are both state and federal COVID-19 relief funds. Without those relief funds, the total expenses in 2020 on the aggregate level would have exceeded total revenues, total operating revenues that we saw at hospitals. So if you go to the next slide, we'll break that down by cohort. So here, each cohort has a dark circle, the dark blue circle, which represents its total margin without COVID relief. And then the light blue square at the top is total margin after COVID relief. So across all hospital cohorts, we saw negative total margins without the COVID-19 relief funding. But then once we factor that COVID relief funding in, all the hospital cohorts had positive median total margins. So this is a trend we saw across the board, all cohorts. And then our last slide that I'll be talking about is just similar to the first slide I spoke about on total and operating margins, except this data is at the hospital health system level. So we collect data at this level as well, and that includes all the acute hospitals within a system, as well as the non-acutes, health plans, and physician organizations. Historically, the total margin and the operating margin at this level is lower than at just the acute hospital level, because those other entities tend to have lower margins than hospitals do on a whole as a trend. But even at this level, from 2019 to 2020, you'll see we saw a decrease in both total and operating margins at the hospital health system level. And that's all the material I have on hospital financials. If there's any questions, I'd be happy to address them. Otherwise, I'll pass it to Emily. If there are no questions.
No, thank you.
And actually, Emily, before you start, I'll say this again. This is another area of where, actually, you can go to the next slide because it relates to the nursing facility piece, is that historically our annual report didn't address nursing facility utilization or finances, but again, because of the extraordinary impact of COVID on the nursing facility industry, and because that is also an industry that CHIA collects data from as part of our rate setting activities with Mass Health, we thought it was important to present a more complete picture of how COVID impacted the state in 2020. And so this is a new addition to the annual report. So Emily.
Thanks, Ray. So these next 5 slides are on the nursing facility industry in Massachusetts. And before I jump in, I just want to mention that all of the data here is from the cost reports that CHIA collects from these facilities. We collect cost reports from all of the 350 plus nursing facilities in the Commonwealth which accept Mass Health residents. There are also a very small number of facilities which are private only. And so I just want to mention that data from those types of facilities is not included here. So this first slide is showing nursing facility utilization by payer type. Utilization is measured in resident days, and this accounts for both short stay and long stay residents. From 2018 to 2020, we saw overall utilization decline by 15.8%, with the majority of that decrease occurring in 2020, a 14% decrease in overall days in 2020. The utilization decline may be due to a variety of reasons related to the COVID-19 public health emergency, including admissions freezes in nursing facilities, a reduction in inpatient discharges into the nursing facility setting, and also increased mortality in nursing facilities. And so in 2020, there were a total of 11.7 million overall resident days. And you can see across all of these years, that dark blue section of the bar at the bottom, that Mass Health is really the most significant payer for nursing facility services. Next slide. Okay. So this is showing nursing facility occupancy rates. Occupancy is a measure of actual utilization of a facility as compared to its capacity. So the proportion of available beds which are filled. In 2018, occupancy was 86%, dropping to 75% in 2020, which is sort of just echoing what we saw on the previous slide with that decline in utilization. This slide is showing total facilities, total beds, and median occupancy by county in 2020. In 2020, there were 357 total nursing facilities that served publicly aided residents in Massachusetts, and the median occupancy rate statewide was 76.7%. The median occupancy by county ranged from 57.9% in Dukes County, which actually only has one nursing facility, to 85.8% in Berkshire County. And the median occupancy rates, both statewide and in each county, were lower in 2020 than in previous years. In all but 3 counties, which is Berkshire, Franklin, and Nantucket, the median occupancy rate decreased by more than 10% as compared to 2018, which are these orange figures that you can see in the chart. Next slide. Thanks. This chart is showing nursing facility median total margin with that orange line. And then also, just to present some additional context, we have the 75th and the 25th percentile with the dashed lines on this graph. Total margin evaluates the overall profitability of a nursing facility, reflecting income and expenses from resident care activities of the facility, as well as other business activities such as investment income, sale of assets, and others. In 2020, the total revenue reported by nursing facilities also included state and federal payments received related to the COVID-19 public health emergency. And so these funds were included in the calculation of the total margin reported in 2020. And you can see from 2018 to 2020, that system-wide median total margin increased from -3% to positive 1.3%. Right, and this last slide is just showing the total revenue and expenses industry-wide. In 2020, with the inclusion of COVID-19 related funding received by the nursing facilities, as I mentioned on the previous slide, we're seeing that the total reported revenue is slightly exceeding the reported expenses, which is actually a reversal in the trend from the prior 2 years. Any questions about the nursing facility section that I can answer for folks? All right, thanks. So the next slide is kind of bringing us to the end of the annual report presentation. If you want to just switch to the next one. And so as Emma and Ray mentioned earlier, the annual report exercise is mainly showing data up through 2020, but we do have more recent data in a number of the areas covered. So if you are interested in any of the other reports that CHIA has recently published or will be publishing in the coming months, I would just direct you to our website. We're at chiamass.gov. Thanks.
Thank you, Emily. And I should mention, in addition to CHIA's data, there are other state agencies also. Either they have data about their own populations, like Mass Health, but the Division of Insurance, for instance, has lots of data from commercial insurance carriers for fully insured members, and we've met with them and just trying to understand what they have in terms of information about more recent utilization patterns. So anyway, there's more data than we present in the 2020 report, but we think it's very important to have these annual snapshots. But I think, Laura, to your point at the very beginning, is that I think from going forward, this is going to become much more about trend analysis and rolling averages and multi-year views of things, as opposed to just the one-off static measurements. So it's going to be changing.
Thank you to everybody. First of all, I thought it was lovely to get to meet the team, and your handoffs were really good. So well done, team. Are there any questions from council members? There was a lot in the report. I'm looking. Okay. Hi, Meredith.
I have sort of an overarching question. You know, I love data, and I found all of these presentations fantastic. I agree with you, first of all, Faye. I love that this has been a presentation of all the frontline experts. So that's great. Congratulations to all of you. These data have so much to teach us. I wonder, as a perennial question, how can we disseminate them so that they really get the interest of more stakeholders around the Commonwealth? It's of course wonderful that so many of the state agencies rely on these data, but how can we get people to sort of pick them up and understand what's going on in our health ecosystem?
It's a great question. I will say that one thing we've just started to experiment with at CHIA is a kind of data storytelling techniques. And so we actually have a like a 1.5, 2 minute long narrated video introducing THCE in the annual report, just as an attempt to create a hook for people into the material who might, find it more accessible to look at just a short video. So I'll circulate to the Oversight Council. It's on, you can get to it sort of on our website, the landing page of the annual report, but I'll circulate the link. We're very open to try to find new ways to disseminate. Frankly, as the volume of our publications gets, it keeps increasing, we're running into issues of stepping on our own publications. And so it's sort of a good problem to have, but we put out so much material, we are going to have to be more creative in terms of thinking about how we create those hooks. But we do have some data storytelling that we can share with you around the annual report.
I just wonder if you ever deliberately try to feed them to people like Martha Biebinger or others, because these, especially the health equity report that we were listening to seems like it would have legs with a general audience.
Absolutely, we do. And they're part of our general distribution, but I think we should probably pick our spots and take certain. We generally don't self-promote. We sort of put the material out there for people to consume. We should probably take some of our, higher profile or more cutting edge publications. The health equity one's a good example, and maybe do some promotion, a little more promotion rather than just passively putting it out there.
Yeah, Meredith, I think it's a great question, and it's, we've got the data, here are the facts, but I think people really want to understand why, so what, all those other great questions, and how do we get more people to take it and really dig into it and help people with a context and an understanding? That would be great. David, are you on?
I know at one point David had to jump for a call, but yeah. I will say that our data really does feed into the work of many of the other state healthcare agencies, and so kind of we perform one set of analyses and then hand it off, and it does get used extensively for other purposes.
Yeah.
And also by researchers, as Meredith can attest.
Yes. And then the researchers have to figure out how to get it broadly disseminated too.
And I will say, as I said at the start, so virtually everything you saw today, other than the hospital and the nursing facility financial presentation slides, comes from aggregate data that we collect from the health plans. And so it's wonderful. It has many inherent advantages, but it doesn't lend itself to deep dives. And so the enhanced all payer claims database is just coming online after kind of years of work to make a much more flexible analytic tool. And so it really is, I think now we're at a point where we can start thinking about what are the research or analytic questions we want to pursue that go beneath these top line numbers. And so that's something that the Oversight Council should certainly be thinking about. And then we're very happy to hear people's thoughts on what is it that you would like to see us drill down on more.
It was great. And again, thank you. Any other comments before we hear a motion to adjourn? I wait to hear a motion to adjourn.
So moved.
Second.
Great. Thank you. Thank you, team. Really very rich conversation. Thank you to all members of the council. And I can't wait till we have a meeting in person.
Exactly. Hopefully the next one, I would hope.
Yes, June, right?
June. Yep.
Fingers crossed, everybody, that we will see each other in person on a bright, sunshiny, warm day.
Yes. Thank you so much. Have a nice day, everybody.
Thank you all.
Thanks, everybody. Bye.
Thank you.
Thanks. Bye-bye.